Great. So welcome to this webinar on extracellular matrix and neuroscience. My name is Signe Holm Nielsen, and I'm very excited to be moderating this webinar today on behalf of the Extracellular Matrix Pharmacology Congress and these webinar series. So today's topic, as you can see in the slide, is really the brain's breakdown, where we're going to talk about biomarkers, the extracellular matrix, and focus a bit on neuroinflammation and neurodegeneration. So before I introduce the first speaker of today, we have a really nice lineup of 3 experts within this field. I would like to highlight that in June 2026, the 15th to the 17th of June, we're going to have the biennial meeting of the Extracellular Matrix Pharmacology Congress. It's going to be in Copenhagen, Denmark, so hopefully Copenhagen will invite us for a nice and sunny time in June. It's not always the case, but we cross our fingers and hope for it. And then a few housekeeping rules. If you have any questions to the speakers today, you can in your top right corner find both chats. It's called private or public, where you can ask questions. There is also a Q&A. And after we have heard our 3 excellent speakers, I will go through a Q&A sessions where we will invite all the speakers back to the stage and discuss these questions that you may have asked during the webinar. So the first speaker of today, let's get started. And the first one is Professor Dr. Charlotte Teunissen. First of all, she does not need a lot of introduction, to be honest. Professor Teunissen is a full professor in neurochemistry. She's really dedicated to improve care for neurological diseases and patients, and really one of the key researchers in body fluid biomarkers. So she's not just a leader in Amsterdam and the Netherlands, where she's running her lab. She's really an international leader in the field, and I think you have at least crossed 700 publications. It's somewhere like that on PubMed, and really serving as a chair for the CSF Society, coordinating the next generation of neuroscientists through the Marie Curie programs. So really the work of Professor Teunissen has really, or about to shape the future of personalized neurology, really to help these patients do better treatments and really give the best possible care for the patients we're all trying to help. So today, Professor Teunissen will give us a talk on fluid biomarkers for neurodegeneration and inflammation in neurological diseases. So Professor Teunissen, thank you very much for being here, and I look forward to hearing what you will present for us today.
Thank you so much, Signe, for the nice introduction. So indeed, as Signe said, we'll talk to fluid biomarkers for neurodegeneration, inflammation in neurological diseases. And here are my disclosures. So I will talk to the state-of-the-art of blood biomarkers for AD diagnosis. And next, in the second part of my presentation, I will allude on the future. So how can we use fluid biomarkers to predict treatment effects and ideas that we have around that? So biomarkers are important aids in the clinical decision making. So clinical evaluation is key, but biomarkers can tell us about the etiology of the complaints. And we need several biomarkers per the definition of the FDA. So for example, diagnostic biomarkers, prognostic biomarkers, probably after diagnosis, if we try to define which treatments can be applied, but prognostic biomarkers can also be useful in a pre-diagnostic area. And we need monitoring biomarkers to monitor treatment effects. So along the patient journey, we need different types of biomarkers. And we do think that we need different biomarkers and not just one that fits all. So first about the diagnostic biomarkers, because we've made enormous progress in the diagnostic biomarkers for Alzheimer's disease. and they are already ready for implementation in clinics and in trials. So if you look at the right of this diagram, we see that there are 4 biomarkers, essentially 4, that we can use now and measure very well in blood. The concentrations are a little bit lower than in CSF that you see in the middle column, but these biomarkers reflect different aspects of the pathology. So for example, amyloid beta to reflect amyloid plaques, p-tau to reflect tangle formation, neurofilament light for axonal damage, and GFAP for astrocyte damage. So you see other mechanisms as well, and ultimately we think that we need to have biomarkers in our hands that reflect also other mechanisms in order to better explain the heterogeneity between patients. But for the 4 biomarkers, we made enormous progress, and especially for plasma p-tau. So here you see a graph that's very typical with all the different studies that are and results that have been obtained for the p-tau biomarkers, namely that you see a specific increase only in 80. So compared to controls, healthy controls to the left, but also to other diseases that involve tau pathology. So this is really a specific biomarker for Alzheimer's disease. In MCI, it's in between. So this is a relation in this study compared to clinical diagnosis and plasma p-tau 181, but there are other plasma p-tau biomarkers that show the very same effect. But not only is there an effect shown, a relation compared to clinical diagnosis, also a relation to the right with PET, with subsequent cognitive change, and also relation with atrophy. So all kinds of readouts in Alzheimer's disease that are relevant, we see a relation with p-tau. And there are not only 30 papers, but there are more than 200 papers that appeared over the last 2 years, and perhaps in the meanwhile already more. But we listed 30 that are relevant and included in the recently launched a launch for public response of the Alzheimer's Association, a meta-analysis. So this is the roadmap for biomarker development, and it shows you how biomarkers are being developed through those different phases. And important and exceptional thing is for the plasma p-tau biomarkers, we are already at the 5th phase, and that's only within 5 years since the first papers. So that's really a remarkable speed. So we're implementing them now already. And there are several implementation studies ongoing. So here are listed only the implementation studies that are ongoing in Amsterdam, but there are others ongoing worldwide. Some of these are also international studies. And within the studies, we measure the use, we evaluate the value of plasma markers in different aspects of the care system. Within the Netherlands, a person goes to the general practitioner where only a cognitive test is being done, and sometimes even not that. And then a patient, if the general practitioner has the feeling that there is something ongoing, then they're referred to memory clinics and can also be directly to tertiary memory clinics, so really specialty clinics. So, and we're evaluating whether it's a role of the plasma biomarkers in each of these tiers of the patient referral system in the care system. And for now, after some learnings, perhaps we think that in the Netherlands, the position is mostly in the memory clinics and tertiary memory clinics. And why is that? Well, we also observed some resistance. Resistance, but also we think that due to the nature of the Dutch care system, perhaps the role is rather in the second line. There are questions also raised whether, what to do with biomarkers, how to order them, and how to deal with the tubes. And learnings from CSF analysis helped us define and prioritize such pre-analytical variation, stress testing, way early in the development process. So we set up a very large study sponsored by the Alzheimer Association to study the effect of variation all aspects during the sample processing. So which tube should it be? How long can we keep them at the bench or at room temperature before we start centrifugation? And and also other aspects like storage temperature. So based on these very extended studies, multiple platforms, multiple biomarkers, we now came up with this consensus flow. So I won't go through it, but it's now submitted, and we hope that we can share this protocol very soon with you. It's a consensus protocol, so I'm quite sure that this protocol will stay, and the paper needs to be accepted still. So other aspects that need to be developed for implementation is the development of guidelines. And very important one is the one of the WHO, but also the guidelines of the Alzheimer Association and International Working Group. And what they all have in common, they have different aspects, but what they have in common is that the intended use and the target population is those who are cognitively impaired. So not unimpaired or subjective complaints, no, cognitively impaired individuals. And why is that? Because the risk of false positives is very high in cognitively unimpaired individuals. So that's very important. So very short introduction on state of the art, and now move on with the biomarkers to predict treatment effects. And so this is a hypothetical model that we defined to work, and for the different factors that can influence treatment responses. So, for example, the levels of amyloid and tau pathology make sense. They will define whether you have a positive response or not. But disease drivers, key processes involved in Alzheimer's disease, they are also relevant, and I'll explain in a little bit. And molecular subtypes within the AD population that explain heterogeneity, but also the presence of co-pathologies. So first about A-beta and tau pathology. So they are very relevant. They have been the basis of the successful trials now because they were the basis of the inclusion. So patients had to have amyloid pathology to target amyloid. So this is the right target, and that's very important. And it's also relevant to know that the treatments work better if the level of p-tau or tau pathology is not that high. So those biomarkers, core biomarkers of Alzheimer's pathology, are also very important for stratification. Disease drivers, we think they are also very important to define the treatment response. So how to define these? Well, there are different pathology involved, not just amyloid and tau. And to understand how important these are, or which other pathologies are there, we performed proteomics. And as a readout, we looked into the earliest biology and also the biology that's related to disease progression. And with that, we are able to capture the full complexity of mechanisms that's depicted at the left side of this graph. And in that way, we hope to identify novel drug targets, not only biomarkers. So for the disease drivers, as I already said, we performed a proteomic study and compared amyloid negative and with amyloid positive individuals and those who are cognitively unimpaired, so in the preclinical stage. So included 232 cognitively unimpaired who were amyloid negative and 65 who were amyloid positive. And we used proximity extension assay, which is an antibody-based proteomics method, and we did that because we reasoned that antibodies are also the method of choice for routine laboratory tests for protein analysis. So if we use antibody-based sandwich assays already at discovery periods of our studies, then we would be able to develop successful tests and validated tests better than we did before with mass spectrometry analysis, because then we only had failures. So, okay, here the proteomics analysis, and in this cognitively unimpaired stage, we already identified just over 100 proteins that were regulated. So 68 up and 34 down in amyloid positive individuals. And we were capturing different disease mechanisms. Top was immune function, but also protease inhibition and lipoprotein metabolism and lipid transport. So these all make sense in Alzheimer's disease. So I identified some new ones, but also some biomarkers that we were familiar with already. And based on this multitude of biomarkers, we don't want to measure them all the time. So we modeled a panel, and we need only 12 proteins, again reflecting the same mechanisms and also some added mechanisms like lysosome activity and dopamine biosynthesis. But using those panels of 12 proteins, we could already discriminate amyloid positive from negative very well. But next, we evaluated how this panel could predict progression, clinical progression to AD or MCI and versus non-progressors. And here, using this panel with an area under the curve 0.84, we could already define those individuals who later on progress very well. Now about the molecular subtypes, they are also relevant. So the idea is that there is heterogeneity within the AD population, and that's caused by their different biology, and this is the hypothesis of Betty Times and P.T. Visser, by advanced clustering, they identified indeed 5 subtypes within the AD population. And those subtypes are composed of individuals who have a correlation of proteins within their CSF. And that's how they are characterized. And there are some upregulated that you see by the red bars. So within each cluster is a dominant upregulation or a dominant group of proteins. And that dominant group of proteins gives the name to the clusters. So, for example, the innate immune activation cluster is very relevant, but also blood-brain barrier impairment cluster. So what does it mean? Well, if you look at the innate immune activation cluster, subtype 2, it's composed in a study of 30% of the patients that belong to this cluster. And these patients not only have this CSF biological signature, but that means also something. So this group is enriched for genes that are related to the immune function, risk genes for AD that are related to immune function. They have the highest tau levels and highest atrophy rate, and they have the worst disease prognosis, which you can derive from this atrophy rate. So this subtype not only is something meaningful within the CSF or as a biological grouping, but it has also a clinical meaning. So this will explain heterogeneity and beyond what's already explained by genetic variation. So it's very relevant because they are immune dominant. Probably these have different effects of therapies targeting immune system or of treatments involving the immune reactivity, like amyloid-targeted treatments. And of course, we need to define that, and that's ongoing work. So the proof of concept is now ongoing. Lastly, other factors that are really also important for defining treatment response, we hypothesize, is the presence of co-pathology, because co-pathologies occur very frequently in AD, so like Lewy body pathology with TDP-43 and also vascular co-pathology. And one of them is the Lewy body disease co-pathology. And for that, we have a very good assay that we can use, or it's using CSF, cerebrospinal fluid, and it's alpha-synuclein seed aggregation assay. And it has been shown that positivity on this assay is predictive for steeper clinical and biological progression. So very relevant. However, there is a problem. The seed assay has a binary readout, yes or no. And we need quantitative biomarkers if we want to see a treatment effect or a level difference. So we're up to looking into the quantitative biomarkers. And for that, again, we performed a proteomics analysis with the proximity extension assay. And in this case, we compared Lewy body dementia patients to controls. Again, CSF. So here are the results. There are not so many biomarkers upregulated, more downregulated in DLB, but one of the markers was DDC. And DDC is dopamine decarboxylase. So it's an enzyme, aromatic acid decarboxylase, that is very relevant for the metabolism of dopamine, or the synthesis of dopamine, I should say, from L-DOPA. So it's especially relevant because nowadays there is a staging system defined for alpha-synuclein diseases, where the first biological anchor is the presence of pathological alpha-synuclein, but the second anchor is dopamine dysfunction. So perhaps DDC could be the second anchor biomarker. And we were not the only ones to show this in the Dell company, but others observed that as well. But always with proximity extension assay or SomaScan, another proteomics method. So we thought that we should have an immunoassay, and we started to develop such an immunoassay for DDC, and we were very successful. So if you think back to our aim to develop and validate novel biomarkers for clinical use from this antibody-based proteomics method, it looks like that we are quite successful in that. So we developed 2 assays on the ELA system and the Simoa system, and we could validate our original findings. So that's of note. We couldn't do that so well in our earlier mass spectrometry discovery studies. So this looks, a nice method. So again, we replicated the DLB increases compared to controls and also to AD. And we validated this finding in multiple other cohorts, independent cohorts. So here's one with autopsy confirmation for DLB. So also a nice increase. Here's another cohort where at the purple bar at the far right, you see PD patients, Parkinson's disease. Also here we observed increases in DDC. And here are the corresponding areas on the curve. So on the blue line, DLB versus control, purple, DLB versus AD. So high area under the curve. And if you look at the third block Biodem Antwerp autopsy cohort, we see an area under the curve for DLB versus control that's almost 1. You see a very tiny blue line. So very promising. So in conclusion, plasma biomarker implementation is crucial for starting and monitoring disease-modifying treatments in any disease, you would say, but for Alzheimer's disease, we've now proof of concept. And we need monitoring and pharmacological biomarkers. And for that, we think we are now at the brink of studying that, but it's nice to think about hypothetical frameworks for that. And we think there are the 4 major aspects that can define treatment response, but perhaps there are more. And we need to study them. I also think that these upper 2, dus AD and tau pathology, the core biomarkers in Alzheimer's disease, and also the disease drivers are the markers that we want to see change in, and that can be used for monitoring positive effects of treatments, so to monitor a treatment response. And with that, we need panels, naturally. And with that, I'd like to thank you. And I hereby also want to acknowledge the team science in my neurochemistry lab and also in the Alzheimer Center Amsterdam, and also the contribution of all our collaborators all over the world. Thank you for your attention.
Thank you very much, Professor. And that was really an inspiring talk, and I think really how you can say move the p-tau SS forward so quickly is extremely impressive. So really congratulations with that work. So there's a lot of questions coming in for your talk, and we'll save them for the Q&A in the end. So I will say thank you for now, and you can leave the stage. And then also, even though Dr. Tunissen just finished her talk, you're always welcome to ask extra questions in the chat or the Q&A. And then I would like to introduce the second speaker of today. And the second speaker of today is Professor and Dr. Tobias Seibek. So Professor Seibek is head of research and neurologist consultant at Esbjerg Hospital. He's heading the research with affiliation to University of Southern Denmark. So he's really been at the university during the past 15 years, and during the past 6, been responsible for the neurology research, specifically in multiple sclerosis. So he's really a medical doctor that sees the MS patients. He's a PI for several clinical MS trials like Gemini and Hercules, where new treatments are being tested on MS patients in different clinical trial settings. So Professor Seibek, I look forward to hearing what you will tell us today about neuroinflammation, biomarkers, and upcoming treatments in multiple sclerosis.
My name is Tobias Seibek. I work as a consultant neurologist in Esbjerg Hospital at a newly founded research group as both consultant neurologist and assistant professor and head of research. Regarding the definition of multiple sclerosis, already in the end of the 19th century, Jean-Martin Charcot described the pathophysiology and symptomatology regarding MS, and these are still hallmarks within MS, but have of course evolved widely since. This slide shows the Charcot's definition and naming of MS, and also the Dawson reports that is nowadays called the Dawson fingers. That is specific MRI finding markers and specific biomarkers for MS. We later on had the CSF abnormalities and animal models describing pathophysiology in MS, but the first available therapies came in the early 1990s and is nowadays considered only moderate effective, and we got access to the first highly effective therapy in 2003 with natalizumab, and later on fingolimod. And as you can see here, they are sort of naming it the first, second, and third era, with the first as the descriptive and early therapies, and later on the more highly effective therapies, and later on again a widely variety of therapies available, and it didn't stop in 2014. We're having new therapies available on a yearly basis now, but they are unfortunately still primarily in relapsing forms of MS. And regarding relapsing form, we have here in the upper left the phenotype describing that in the relapsing forms of MS we have symptoms onset and later on recovery, and then a period of time, an interval between until the next relapse, and the relapses are early in the disease without the accumulation of disability, but you can see later on there is an accumulation of disability. 9 out of 10 patients start with this type of MS, and the last 10% starts with this primary progressive form of MS, where there's an absence of relapses throughout the disease course. Over time, and after approximately 10 years, half of the patients with relapsing forms of MS will have developed a secondary progressive form. And the last form in the lower right, the benign form, is I would call a retrospective diagnosis, and something that we only look back and call it hindsight, because to most patients, MS can be quite, especially if untreated, quite a severe disease. I think in a way we are looking into the fourth era of MS right now, because we see a shift regarding that therapy available for treating progressive MS is in the nearest future. This slide is demonstrating what is happening early in MS and later on in MS. And when I say early, I mean primarily in the relapsing form of MS, where we used to talk about the clinically isolated syndrome, which is the first relapse in MS. And with the new 2024 diagnostic criteria, we will move into a time where the diagnosis will come even earlier. And as you can see, the the disease is driven primarily by neuroinflammation early on in the relapsing forms of MS, and over time the neuroinflammation is declining. But also you see an acceleration of brain volume loss throughout the disease course. And throughout the disease also a neurodegeneration from early on in relapsing and also later on in progressive forms of MS. What is demonstrated here is that you in the early forms of MS usually have relapses with quite good recovery, but also accumulation over time of disability, and also that relapses are getting a less pronounced part of the disease in the progressive forms, but unfortunately also accumulation of disability is seen throughout the disease in progressive MS. And regarding the early and late pathology in MS, I think this slide, and with courtesy to Hans-Peter Hartung and his group in Frontiers of Immunology, was demonstrating the early and late disease, that early in the disease we have a lot of white matter demyelination, especially periventricular, but throughout the brain, and also with a cortical demyelinating, but where there's also a switch regarding the late phases where we see a deep gray matter demyelination, and also a accelerated brain loss in the lesions with previous demyelination, and also an increased enlargement of the ventricular system due to brain volume loss early in the disease. We see a driver in the disease that there's an influx from the systemic compartment into the CNS compartment of especially T cells that is being activated and causing a lot of inflammation in the central nervous system. So both B and T cells play a crucial role in early relapsing forms of MS, and especially also B cells in the later forms where they are thought to have this lymphoid-like structures and causing compartmentalized inflammation in follicles, and also having a metabolic stress and there's a loss of neuroaxonal, both oligodendrocyte damage and neuroaxonal loss and degeneration. So there's a switch from the early phase of the disease where there's an influx from the systemic compartment, and later on in the disease there's a more pronounced follicularized inflammation within the CNS. And what are the drivers in MS? I just wanted to stress here that so many things have been investigated already. We know that Epstein-Barr virus plays a role in this fundamentally in the development of MS now. We know that specific tissue types like HLA-DRB1501 is a risk factor, but they are also quite prevalent. We know that 1 in 5 of the Danish population have these subtypes. We know that smoking and the season of birth, if you're born in May, and maybe related to that your mother was pregnant with you during the winter time, is the prevalence is higher, but not that much higher. We know that insufficiency of D vitamin is also a risk factor, and childhood obesity, and the heritage of if you have parents or a twin with MS, then the likelihood of getting MS is higher. But all these factors are never 100%. We know that 3 out of 4 women. And I just want to stress with this slide that so many other things have been investigated. If you are eating butter or drinking coffee or whatever has been investigated. So we know a lot, and we are also moving within understanding the disease. The understanding of activity and phenotyping progressive MS has changed the way we treat MS today, and is also one of the reasons why we see effectiveness in novel drugs. First of all, you can be in that lucky situation that you have progressive MS and that your disease is stable. It doesn't really matter if you have a primary progressive MS or secondary progressive MS. What the ongoing pathology behind is quite similar in both types of progressive MS. And then you can be in a situation where you have no activity, and activity is defined based on if you have new lesions on your MRI, new T2 lesions, enlarged T2 lesions, or contrast enhancement, GAD enhancement, or relapses. So you can be in the situation that you have progressive disease, but no activity. Then you can also be in the situation where you have new changes on MRI, but no progression. And you can be in a situation where you have clinical disease progression and you have activity. And I think that's important right now for us as clinicians, because we can treat the activity pretty effectively with highly effective drugs such as anti-CD20 or natalizumab therapy. This slide is demonstrating different mode of actions and therapies. Up in the lower left, we have the old therapies like interferons and glatiramer acetate, and also dimethyl fumarate, which are we used to call them immunomodulatory therapies. They, for example, dimethyl fumarate is inhibiting nerve2 and the NF-kappa beta pathway. It's not highly suppressive therapies. They have a moderate efficacy. For example, teriflunomide, where a subset of T cells involvement are being limited, and by that the proliferation is limited, and also activity on MRI and relapse is reduced, but only on the left side here on a moderate level. Over to the right side, you see examples of highly effective therapies, and up in the upper right, we have a targeted cell lysis. It could also, and more today more widely used with the anti-CD20s, a specific monoclonal antibody that do a cell lysis in B cells specifically. Or we have the migration, the therapies where, for example, natalizumab is inhibiting the alpha-4 integrin, and therefore giving a blockage so that the cell cannot roll, they cannot contact to VCAM and roll on the endothelial, and then migrate into the CNS. So on the right side, we have these highly effective therapies that are highly effective if you have a systemic involvement of inflammation in the CNS, as we see in the highly effective therapies. And we learn a lot from these therapies regarding understanding MS and relapsing forms of MS. But one of the issues is that these drugs are not penetrating the blood-brain barrier and entering the CNS if they would work there. What we see is in progressive MS is that we have activated microglia. We have a creation of iron particles, and also a creation of iron rim lesions, which has been described as slowly expanding lesions. We also see meningeal lesions with leukocytes that aggregates into complexes and contributing to a cortical atrophy. We see activated lesions with leukocyte aggregations and this iron rim surrounding the lesions, and we have older lesions with focal substance loss and less infiltration of inflammatory cells. We see microglia, we see activated T cells, we see oligodendrocytes that are doing remyelination, we see intracortical lesions that are giving a substance loss. So that there are distinguished phenotypes in progressive and relapsing forms of MS that are present at both stages of the disease, but where in the progressive forms we have more slowly expanding lesions, more meningeal inflammations, and these slowly expanding lesions are probably being demonstrated as a MRI biomarker. In the rim lesions, we see a cortical demyelination and a neuronal loss in general, and we have in relapsing forms of MS we have more active lesions that are being visualized with new lesions on MRI GAD enhancement, T2 lesions, but probably also if reflected on levels of neurofilaments, and we have whole brain atrophy, and And we have lesions in relapsing forms that are pre-active, and in progressive MS we have this more microglia activation, which is probably a primary driver in progressive MS. So there are distinguished differences between the types of MS, and probably also how they should be treated. One of the issues is that this compartmentalized inflammation within the CNS and the blood-brain barrier being more closed, and the drugs that are effective on the systemic compartment not really working in the progressive forms of MS. So several mechanisms of injury in progressive MS are seen, and in a way the areas are again represented with B, C, D, F, E, G here. I deleted A because it's the systemic compartment again, and as I said previously, that is we have older and established therapies that can close down the inflammation from the systemic compartment. But one of the lags, for example, in B-cell depleting agents is that the penetration into the CNS is not high enough, and the activation is not good enough due to several reasons. For example, lack of complement activating factors. But in the leptomeninges, we do see these T and B cells present in the perivascular cuffs, and thereby they are causing localized inflammation and increased cytokines and these follicles these leukocyte aggregates, and thereby we also see myeloid neuroinflammation that is causing neuronal destruction and also destruction to astrocytes. And I'm sure Dr. Tønnesen will have mentioned GFAP as a marker of astrocyte damage. Again, we have a disruption of the metabolism within the CNS, and these different areas are areas where biomarkers can be used to target and express this, and also novel therapies can target these domains and hopefully help preventing progression in multiple sclerosis. And I just wanted to give this example. We have, for example, these 4 therapies, and if you look at if they cross the blood-brain barrier readily, since, for example, alemtuzumab, it's a large monoclonal antibody, it does not penetrate. It was also negative in progressive trials, but it's really highly effective in removing B and T cells. Cladribine and dimethyl fumarate and also fingolimod, they have the size where they should penetrate. They could also have antioxidative effectiveness or inhibits parts of microglia reactivation, but they have in a way all failed in preventing progression in MS. Fingolimod is a quite old drug, and it was not the trial conducted was not really well designed regarding identifying activity in progressive MS, and we have seen that sphingosine 1 inhibitors is effective in active secondary progressive MS. Regarding biomarkers, I tried to touch upon it. This is one of the most established biomarkers. It's very old. It's useful in the diagnosis of MS, and if you are negative, it's a positive biomarker early in the disease to not have oligoclonal bands. But we do, as clinicians, think about if patients really do have MS if they do not express oligoclonal bands. At ECTRIMS 2024, we got the new diagnostic criteria, and I just wanted to show, because I mean the people in the audience here are working a lot with fluid biomarkers, but imaging biomarkers are the most widely used in MS right now and the strongest. So, for example, a classic MS lesion periventricular, creating a dorsal finger with contact to the ventricular system. Here, demonstrating a optic neuritis. We have this 5th topography in the new diagnostic criteria, the optic nerve. We have a U fiber here, also quite classic subcortical lesion. We have an infratentorial lesion here in the brainstem next to the right side peduncle. We have a spinal cord lesion in the upper cervical spinal cord. And we have these new iron rim lesions called Pearl's paramagnetic rim lesions, which we think reflects iron accumulation in the ring. And we have these new central vein sign that has been described for 10, 20 years, even more maybe, where they are specific in relationship to MS. So the proposed criteria are that we are able to give the diagnosis even in patients who do not have had a symptom at current, and we are the domains of topographic distribution is being widened to five topographies. You do not need to have demonstration of time regarding as contrast enhancement, new lesions on T2 or oligoclonal bands, but other criteria can also fulfill this, especially the new carbon-free light chain as a tool for the diagnosis of MS. Several good reasons of diagnosing MS earlier is that in relapsing forms and early MS, the high likelihood of having effective therapies, and these numbers by Xavier Montalban and Ekströms demonstrate that a large proportion of people fulfilling these criteria for MS will develop clinical MS. Half of patients will after 10 years have developed symptoms, and even more patients after 15 years. And also that the carbon-free light chains are a valid tool in MS, and probably also prognostic that, as I shown in the previous slide, the oligoclonal bands is not a quantitative analysis. It's a more qualitative analysis, demonstrating if there's you have this electric signal from clonal bands that looks different if you when doing the analysis and being analyzed by specialized lab technicians, but when working with carbon-free light chains, you get a quantitative measure, and this measure is probably also reflective of prognosis in MS, and it's not we are still getting a high specificity regarding the diagnosis, so that's probably also a new biomarker in MS. And in the end of the last 3 minutes, I would like to talk about the new trials in MS on the BTKs, the proton tyrosine kinase inhibitors. We had the results presented at ECTRIMS by Robert J. Fox and D10. We were also part of these studies, and I think it's really novel when you get a new therapy on an indication in a disease area where we were not able to treat before. The background here was that the proton tyrosine kinase inhibitors are limiting maturation on both a B and T cell macrophages level, and it's also CNS penetrant, and it modulates microglia macrophages activation within the CNS. And the studies were conducted like a double dummy with a placebo, and those that got placebo and worsened throughout the study were then received rescue therapy with tolebrutinib. And it showed this 30% reduction of progression, which again is a modest number, but I just want to stress that was how it went with the first therapies in relapsing remitting MS. But what we also learned from this study, and these data were published in New England Journal of Medicine and also at the American MS conference earlier this year, that these paramagnetic rim lesions are predictive of disease activity and progression, both in the relapsing and the progressive cohort. And it looks like here that we have a new imaging biomarker regarding MS, that the more pearls, the more paramagnetic rim lesions demonstrate at baseline, the more likelihood of disease progression, but also the higher likelihood of having efficacy from being treated with tolebrutinib in this study. And I think this is a class example of how we over time learned of subtyping MS and also using other types of measures regarding progression. And paramagnetic rim lesion is, as I see it, the next biomarker within imaging in progressive MS. And I'm sorry for taking a little more than 20 minutes of your time. Thank you to Nordic Bioscience and to Kim and Signe for inviting me to give this talk. I'd like to end the session with a slide from the hospital in Esbjerg, which is the view from our helipad. And I hope you'll have a fruitful discussion on biomarkers and pathology in MS. Thank you for your attention.
Great. Thank you so much, Professor Seibæk, for, first of all, a very interesting talk that sparked a lot of good questions, primarily in the private chat. So please keep bringing on the questions. You're welcome to use the private public chat or the Q&A chat function. It's always, you can say it's great to hear some of the new developments from the Hercules and so on, but also I think we keep on hearing how tricky that blood-brain barrier is. So maybe we're going to have a little bit of a discussion on that later with a bit of drug development and so on perspective. So keep on posting questions, and then I'm really excited to introduce the last speaker before we move on to the Q&A. And that is Dr. Kim Henriksen. So he will dive a little bit deeper into the extracellular matrix. So we talked a lot about Alzheimer's, a little bit of Parkinson's and multiple sclerosis, disease pathology. But Dr. Henriksen is really, he's director of neuroscience at Nordic Bioscience, have been with the company for a couple of decades, I must say by now. But he's really spent his life and career on developing treatments for patients, and also digging a bit more into these fluid biomarkers and how to design the best possible for endocrinology and neuroscience. So Kim, I look very much forward to hearing a little bit more about the matrix and how we can use some of the information from Professor Tunissen and Dr. Seibæk in our ongoing drug development programs.
Thank you, Signe. Yeah, so thanks a lot for the invitation to speak here, and I'd like to introduce you to the field of extracellular matrix biomarkers and how we think that they may actually aid what you've just heard in the two previous very inspiring talks. Because as you can see from both the CSF biomarker field and the imaging biomarker field, these are fantastic biomarkers, but obviously they come with a little bit of challenges, and therefore we've aimed very much on finding something which can be used in blood. And to introduce you to what we think here, I would like to start with the extracellular matrix. And if you come from the brain field, I'm sure that the extracellular matrix is not at the top of your Google search list or your PubMed search list. But bear in mind that the extracellular matrix is the scaffold that surrounds most of our tissues or organs, and it is super important in the brain as well. There have been numerous studies by now indicating that the changes in the extracellular matrix, particularly surrounding the blood-brain barrier, are very prominent in neurodegenerative disorders, and therefore we thought that there was potential to apply some of these, particularly when you look into the processing of the extracellular matrix. And just to illustrate why we think processing of the extracellular matrix is super important. This is really the core of what we try to do when we develop biomarkers. Our biomarkers are really intended to speed up clinical trial decision making. So what we try to do is to develop biomarkers, which is illustrated in the lower left corner of this slide, which very rapidly and with a high sensitivity respond to a given treatment. And that's of course super important in clinical trials of drug candidates, because the faster or the earlier you can measure a change in your biomarker that predicts a disease-relevant outcome. It could be Professor Seibæk's rim lesions, or it could be a change in cognitive symptoms in Alzheimer's patients. But if you can really pick up a biomarker that at a very early stage measures a response to treatment, so you can make a decision on whether you should move your drug forward from phase 1 to 2 or from phase 2 to 3 for that matter. That will clearly help your drug development a lot. So the overarching aim of what we try to do with our ECM biomarkers and other post-translational modifications is really to aid the drug development to make decisions earlier. And when you look into what the extracellular matrix is, it's a rather complicated structure. In total, there are 28 collagens alone. On top of that, we have elastin, we have laminins, and we have different isoforms of these. And the important thing is that they form a very, very important scaffold. And this scaffold is highly individualized for the different organs, with some organs presenting one type of scaffold and other organs presenting another type of scaffold. But in general, you can sort of simplify it a little bit by having the basement membrane, which contains a certain component of collagens. Very prominent one is type 4 collagen, which I'll return to later, because the basement membrane surrounding the blood vessels in the brain is one of the areas that really needs attention. And on the other opposing side of the matrix, we have the interstitial matrix, which is rich in fibrillar collagens like type 1, type 3, and type 6 collagen, which are super exciting across a host of different diseases we've been studying, but have not really come onto the radar in the neurodegenerative space at this point in time. So how do we really do this? Well, we don't really monitor the intact collagens. What we try to do is to identify fragments, pieces of collagens that reflect either synthesis of new collagen, that would indicate a deposition of new matrix, or fragments that reflect the degradation of the matrix, i.e. loss of that specific collagen component, which then reflects loss of that collagen. And we've done so illustrated here by type 1 collagen for simplicity, because in type 1 collagen we have two different fragments indicating synthesis, the N-terminal propeptide called P1NP or the C-terminal propeptide called P1CP, and they are known to really very accurately reflect whenever type 1 collagen is deposited. On top of that, there are numerous degradation fragments. I've shown just 3 here. Two of them have been developed internally at Nordic Bioscience. C1M is an MMP-generated fragment of type 1 collagen, which comes from the intrahelical part of collagen, and which is very closely related to inflammatory processes, even in the brain. And then you have a degradation fragment such as CTX1, which is generated by cathepsin K. And for those of you who've run into the bone field, you will note that that's a very, very useful bone degradation marker. So all in all, what this means is that processing of the collagens produces fragments that are related to the turnover in the individual organs. And that turnover is often related to disease progression. So with that in mind, it's time to switch a little bit into the brain. And in terms of the matrix of the brain, there are 3 types of extracellular matrix in the brain. We have a basement membrane, which is quite similar to the basement membrane in most other organs. It's rich in type 4 collagen, for example, and it's rich in laminin. So from that end, it fits nicely into the general description of basement membranes. On the side of that, we have the perineuronal nets and the neural interstitial matrix, and these are quite specific for the brain. And compared to other organs in the body, the brain is very rich in proteoglycans, both heparan sulfate proteoglycans, chondroitin sulfate proteoglycans, and these are really prominent across these 2 types of extracellular matrix. And I think by now we're just scratching the surface of the promise of these matrices as biomarkers across neurodegenerative conditions. So when you look a little bit into the neuronal pathology, as you've also heard from Professor Turnison very earlier today, in many cases it starts with neuronal death. In this case, we've illustrated it by alpha-synuclein aggregates. It could also have been tau aggregation triggered by A beta accumulation or so. But in most cases, where the disease starts is centered around the neuronal degradation, and that's really triggered by a proteinopathy. And brain disorders are very, very well known for having dysfunctional protein regulation, leading to aggregation of various proteins. It could be alpha-synuclein, it could be tau, it could be others. And when these start aggregating, the neurons start dying or degenerating and dying. As an aside to that, there are some other processes most likely related to a repair of or an attempt at repairing the damage that happens. That means the remaining cells in the brain, the microglia or the astrocytes, and even to some extent the cells surrounding the blood vessels become activated. And that triggers that when that then has reached a certain level, it triggers damage, and you have blood-brain barrier leakage, and you have neuroinflammation. And these two processes are, as you've heard a little bit about in the earlier talks, becoming more and more prominent because they clearly contribute to the pathology of the neurodegenerative diseases, but monitoring these has so far proven relatively difficult. So that leads me to what's really the need in the neurodegenerative space. And here I'm again speaking about the people we mostly work with, namely the pharma companies who try to develop drugs for these complex disorders. So as you've heard, there's clearly the need for biomarkers which identify people who progress fast. These are obviously the ones that are in the most need of treatment, and identifying those is super important. Then on the side of that, and as drugs become better, and obviously that depends a little bit on the disease indication, but as the drugs become better and become more disease modifying as opposed to symptom modifying, the biomarkers that reflect an actual response to disease modifying therapy become really, really important. And by now it's also become clear that you need biomarkers that monitor neuroinflammation and biomarkers that monitor blood-brain barrier integrity to make sure you can tailor your treatment for the individual person correctly. So again, coming a little bit back to why we think that our protein fingerprints, as we call them, fragments of proteins are relevant. This is a very simple schematic illustrating when a protein becomes fragmented, it has two relevant outcomes in our mind. One is it becomes smaller, and smaller fragments do have a tendency to cross the blood-brain barrier more easily. So that's a good thing from a biomarker point of view if you're working on generating a blood-based tool. The other thing is that, as mentioned before, fragmentation is related to the underlying pathology, and that means that these protein fragments, they often carry pathophysiological meaning and in many cases are actually related to the rate of the underlying pathology's progression. So from that end, we really like the combination of these things for the neurospace. So what we've done is that we've been working on generating a neurobiomarker panel. I'll introduce you to a couple of them as we progress. But here they are. So we've been working on two categories. We have the ones that are directly related to the degenerative processes that happen in the brain. We have a fragment of alpha-synuclein, which relates to the neuronal pathology in when alpha-synuclein gets cleaved, for example, in Parkinson's disease. We have a biomarker that reflects microglial activation. We have an astrocyte activity biomarker called GFAP-C, and we've at an earlier stage developed a biomarker that reflects neuronal death related more to tau aggregation than alpha-synuclein aggregation, which I won't come much into today. As an addition to these, we've been working very much on biomarkers that reflect matrix turnover and are related to the degeneration of the blood-brain barrier. We have a collagen 4 fragment, which I find very, very exciting, and I'll return to in a few slides. And then we have some other fragments which are related to nitrogen degeneration. Again, something which is rumored or which has been described as being relevant to blood-brain barrier integrity. We have a biomarker that reflects damage-associated, damp triggering, I lost the word, I apologize for that, called BGM. And finally, we have a biomarker that reflects neutrophil activity. And as you probably know, neutrophil activation is super important across a host of different diseases. And it's involved in triggering many lesions when it goes badly. But to start out with, I'd like to illustrate just a few points on what we've been trying to do when we're measuring the extracellular matrix turnover in multiple sclerosis. And just to remind you what happens in multiple sclerosis when you look at it at the lesion level. To the left, you have the normal white matter, which, as mentioned before, is rich in various proteoglycans and centered around the blood vessels. We have the basement membrane, which is rich in proteoglycans, but also in type 4 collagen. And then when the lesion arises, the white matter turns super activated, but there's also a sort of a fibrotic process going on centered around the basement membrane of the blood vessels, which leads to an upregulation of a molecule called glycan and of type 4 collagen, and a host of other pathological processes centered around the blood-brain barrier. And we find that very intriguing. So we measured a series of our biomarkers, starting from the left side with our damp triggering biomarker called glycan, or BGM. And you can see in this relatively modestly sized cohort, we found that glycan degradation is actually elevated in multiple sclerosis, which we find quite interesting. Similarly, when we measured our biomarker of blood-brain barrier cohesion, we found that this biomarker called NIC, or nitrogen degradation, is also upregulated, really illustrating that there is a very active pathology around the blood-brain barrier in MS patients. Finally, our biomarker of microbial activation is also active. It's also upregulated. Again, illustrated that we can actually, even in relatively small studies, when we try to measure matrix proteins centered around the lesions in the brain, we actually find upregulations in multiple sclerosis. And some of the things we're trying to do with these biomarkers is obviously to determine how will they respond to some of the treatments described by Professor Seibeck. And with that in mind, I'd like to swap to type 4 collagen. And you saw, maybe you didn't notice, but I did, and that's obviously because it's close to my heart. But on Professor Tønnesson's slide, collagen 4 was regulated in the CSF of the Lewy body patients, and we've actually spent quite a significant amount of time developing collagen type 4 biomarkers. And just to remind you why that's interesting, type 4 collagen is critical for basement membrane integrity. It's also very important for the neural interstitial matrix. So in the brain, type 4 collagen is super relevant. And I know I showed the graph on the right before as well, or the figure on the right before as well. But it's just to remind you that actually specifically in MS, the lesions are rich in type 4 collagen, and some are beginning to describe lesions in MS as profibrotic lesions, and there's an interest in measuring fibrosis biomarkers in lesions of MS. So what have we done on type 4 collagen? Well, first and foremost, just to introduce it, type 4 collagen is actually not just one molecule. It consists of, or it can consist of 6 different alpha chains, alpha 1 through 6, and these form triple helices through various conformations. And these triple helices then form what's called a lattice-shaped network, which is very, very important for the integrity of the basement membrane. What we've done is that we have worked on developing assays that reflect degradation of 3 of these 6 monomers, namely the alpha 1, 2, and 3 helices. So we have these biomarkers, one's called C4M. It reflects degradation of the alpha 1 molecule. We have C4G, which reflects degradation of this alpha-2 molecule, and we have somatostatin, which reflects degradation of the alpha-3 molecule. So we are trying to map out how our collagen type 4 degradation profile works in MS, and we found some interesting data here. And if you look to the far left, you can see the MS data, where we found that the type 3 somatostatin, which reflects degradation of the alpha-3 molecule of type 4 collagen, is very highly upregulated, and we find that quite interesting. Surprisingly to us, because we actually expected that to happen, but the type 1 or the alpha-1 marker C4M is not upregulated, which is quite interesting. So just to expand our horizon on what these collagen 4 markers do, we also measured them in Parkinson's disease, where we can see that both are actually upregulated. And obviously that's quite interesting also because Parkinson's disease is not really rich in biomarkers, but we clearly need to do some more work in terms of understanding what type 4 collagen degradation means to Parkinson's disease. Finally, we also measured them in glioblastoma, which, as you probably know, is a very aggressive type of brain tumor. And here we found that only the type 2 or the alpha-2 degradation marker showed an upregulation. So to us, while we realized that this is just scratching the surface of what type 4 collagen means in neurodegenerative conditions, we find it quite exciting that we see differential regulation of the degradation fragments across different neuronal pathologies. And this is obviously something we're paying a lot of attention to. And now, just to make it a little more confusing, I want to switch gears completely, but you'll see why in a couple of slides. So I want to stick with type 4 collagen, but go into psoriatic arthritis. And that's because disease modification in MS and in PD is not as advanced at this point in time as it is in psoriatic arthritis. And obviously, working with drug developments, it's very important to understand how do these biomarkers also respond to therapy. So what we have here is a treatment study from psoriatic arthritis using deucravacitinib, 2 different doses for 16 weeks. And then what we did was to measure the C4M levels. And what you can see here is that in this, sorry, just to indicate, deucravacitinib is a TYK2 inhibitor, and TYK2 inhibitors are super exciting because they're actually in clinical trials in multiple sclerosis at this point in time. So it's quite interesting to figure out whether we have a biomarker that responds to deucravacitinib. And as you can see in the graph here on the right side, we have a very statistically significant lowering of the C4M levels as a function of TYK2 inhibition, which we find interesting because it could also mean that maybe C4M, when you measure it in multiple sclerosis or other type 4 collagen markers that are more directly related to multiple sclerosis, could respond to TYK2 inhibition. And it should be mentioned that we are actually also able to measure C4M in spinal fluid from MS patients, and it has some sort of relation to the disease. So from that end, we're quite excited about type 4 collagen markers in neurodegeneration, although we still have a little way to go. And with that in mind, I'd just like to switch to using the same technology, but for a completely different target. So now we are no longer talking matrix, but we thought that this methodology of targeting fragments could also be applied to some of the classical brain targets. And if you remember from the slide earlier, I started showing a neuron that had alpha-synuclein aggregation. And it's really important to stress here that there are data in the literature that indicate that one of the triggers of alpha-synuclein aggregation is an enzymatic cleavage by the enzyme called calpain-1. That is, at least theoretically, the initiation of the alpha-synuclein aggregation. So we thought that measuring that cleavage site could potentially allow us to pick up very, very early alpha-synuclein degradation, which would then hopefully be predictive of what happens in Parkinson's disease or potentially even in Lewy body dementia. So what we did here was to look into calpain-1 cleavage of alpha-synuclein, and we developed an antibody that recognizes, or an assay that recognizes this alpha-synuclein fragment generated by calpain-1. And then we went to work in terms of understanding what does that fragment actually mean. So we started out in a very, very simple system using neuronal cultures. And after having mature neurons that express tau and alpha-synuclein and other markers of neurons, we exposed them to a toxic chemical called staurosporin, which very specifically and very rapidly induces apoptosis of the neurons, meaning they die by controlled cell death very rapidly. And what you see in the graph to the right is the control of so the live neurons, and they have an alpha-synuclein level at the detection limit of the assay. And when you add staurosporin, then 24 hours later, the levels start going up, and 48 hours, they've gone up very much. To us, that means, well, this biomarker actually measures neuronal death induced by apoptosis. And so to us, that's of course really, really exciting, because it means we have an alpha-synuclein fragment that's related to the pathology we're trying to measure. Of course, it's super important whether that has any clinical relevance. So we went to work with a collaborator and got two relatively small cohorts. One's a discovery and the other one's an evaluation or a reproduction cohort. And you can see here in these two groups of patients, healthy age, gender, and sex-matched donors, and Parkinson's disease. In the discovery cohort, we saw an upregulation of the biomarker, and we did see the same pattern in the evaluation cohort. So in these two independent cohorts, albeit small, we still see a very interesting upregulation of this biomarker. And obviously, we're hugely excited to continue the work on this one as a potential biomarker for Parkinson's disease. And we clearly hope that it has something to do with progression, but the future will tell. So overall, just to sum up what I've shown you, I ended up with the alpha-synuclein biomarker, which is very close to me at the moment, and we are very excited about the data on alpha-synuclein degradation by calpain. It looks very promising, although we still have a little work to do. And then, as mentioned here as well, we have some very, very exciting data on type 4 collagen degradation. And obviously, it will be super interesting to try to relate the levels in blood and CSF to understand more about the pathology central to the brain compared to what happens in the periphery. But we have a series of very interesting biomarkers coming up specifically for MS and some for Parkinson's disease. So we really think that this combination of fragmentation and matrix can help the neurodegenerative field moving forward, and we are very much looking forward to hopefully at next year's session in Copenhagen present data on disease modification therapies. So overall, what we're really trying to do is to work our biomarkers towards what we refer to as unicorn biomarkers. So these are biomarkers where you have a very thorough understanding of what they do in terms of category. Is it a diagnostic biomarker? Is it a prognostic biomarker? Is it even better? Is it a pharmacodynamic biomarker, something that reflects therapy? Has it been genetically validated? Obviously, that's a tall order in many cases. But on top of all these very scientific things, also regulatory validation, technical validation, to really ensure that when the biomarker is measured in a laboratory, it produces a trustworthy readout every time. You also Professor Tønnesson's slide on the recommendations for how to handle samples. And this is part of what we're trying to integrate in the way we handle biomarkers. So with that, I would just like to say thank you for listening, and I'm happy to take questions as we move forward.
Great, thank you so much, Kim. It's I have the feeling that type 4 collagen is your favorite collagen these days. So that's always great when you're in a matrix symposium, because we always have good friends in the matrix field. So you can still ask questions. I have a big list of questions, so let's start with those, and then we can always expand the discussions. But Professor Tønnessen, I think I'm going to start with you, because the first question that got in is, do you see a blood-derived screening biomarker for routine use in pre-symptomatic Alzheimer's disease on the way? So really, can your GP take a biomarker, select the patients, and then go from there? Do you see that in the pipeline moving forward?
Very clear answer, no. And that's because the false positive rates of the current tests are too high. So that's one reason. And the other reason is that we don't have treatments for all. So for everyone so far. So the tests that we use now, they have been validated in selected cohorts, in memory clinics, and always in relation to cognitive functioning. And that's also what I stressed, and what's also stressed by the WHO, by the Alzheimer Association International Working Group, that these tests should always be offered in the context of use of people with objective cognitive decline. So no, screening is not yet on the horizon. What do we need for that? For example, we need to know, now we need to have drugs that are good for all, and they should be not expensive, with small risk of side effects. But we need also to have better biomarkers, to further improve. Well, they are very good now, but if you go for screening on a wide population range, you need better biomarkers and better prediction of cognitive decline, for example.
Okay, thank you for that. I have it's a very short question, but the answer can be short or long. So I have a question just saying, Tau, which one to pick?
Oh, yeah. Okay. Yeah, I didn't allude on that so much, but the absolute winner is p-tau217. It looks like that in all comparisons, this is a very specific biomarker. I'm not convinced that biologically it's more important than, for example, p-tau181, but apparently the tests are more stable and more specific.
Okay, so we can move a little bit into the stability, because there is also, and Kim, I know you've done some clinical trials, so you can also allude on this, but you had this nice slide with the stability of sample, Professor Tunissen, and a bit of CSF, and Kim also alluded to the blood use and so on. So are the biomarkers and the sampling, are they stable enough? Can we take sample from trials that are already run to test, for instance, p-tau 181 or 217 at the current stage?
Yes, especially from trials, because then usually the sample collection has been very controlled. But the good thing about p-tau217 and plasma p-tau181 is that it's quite stable, so you can mishandle your sample quite a lot. In contrast to a beta-42 and a beta-42-40 ratio, they are susceptible to storage conditions. For example, if you keep the sample at room temperature, if there is some delay in before or after centrifugation, so that doesn't matter, but some time at room temperature will lead to decay. So that's why I'm also a bit skeptical about the current approval by the FDA of a test that measures the ratio p-tau217 to a beta-42, because a p-tau217 is very stable, but a beta-42 is not. Probably the results were promising and good enough, but that they have been obtained in very controlled cohorts, and I do with controlled analytical sample processing conditions. But I expect that in real world, the results will become more noisy. So I'm not in favor for the a beta-42 ratio. Another ratio could be good. We're thinking of BD tau, brain-derived tau, for example. I think any ratio will help to reduce pre-analytical variation effects, but not a beta-42. It should be a more stable protein for that.
Okay, great. So Kim, you finished with a slide saying unicorn biomarker and a little bit of technicality. So how about the matrix markers? Could they complement? Are they different? How stable are they?
Well, and that's a quite good question. And in general, in our experiences, that they are quite stable. Obviously, you need, as Professor Tunissen mentioned, right, you need very careful sample collection. You need to treat your samples correctly when you spin them right, store them correctly and all those things. But in general, our experience is that the stability is quite good, and we've measured samples we've measured some of the analytes in bank samples that are more than 20 years old, and the levels compared to samples that are collected now. Obviously, we are doing very careful sample stability assessments, both using accelerated conditions and things like that when we're developing the assays, to make sure that we understand what is the effect of potential, not according to lab manual handling of the samples, but overall I think they do pretty well, and as long as the blood sample has been handled carefully from the starting point. So the stability for most of our biomarkers at -80 is very, very good.
Okay, that's great to hear. Then we have one question that actually goes for both of you, but with two different, you can say, purposes of biomarkers. So for you, Kim, it's about neurodegeneration and neuroinflammation combined. So you're very excited about your alpha-synuclein biomarker, and I can understand that. But which inflammatory biomarker would you add on to that? And in a second, Dr. Tønnesen will get the question with P217 and inflammatory. So Kim, you can go first.
Well, it's a really good idea, and to be completely honest, I'm not sure we're just there yet. But there are some inflammatory biomarkers, but most of them are, not strongly validated. I think, and I think probably it comes down to doing some sort of CSF to serum correlation studies to understand which, if you want something that you can measure in the circulation, to understand which one actually reflects the inflammation that happens in the central nervous system best possibly. And I'm not sure we're there. I know we have some. I know I didn't show it today. I'm very excited about our calprotectin biomarker, which reflects the neutrophil aspect of the inflammation, because it reflects degradation of calprotectin, and calprotectin is very important for many aspects related to what happens in the brain as well. And when you then have neutrophil-mediated degradation of that, I'm quite excited about that. But again, the data are still a little early, but hopefully, next summer we'll be able to provide some real data on that.
Yeah, it sounds like you both agree that we need a panel, and one thing may not solve it all. So Professor Tønnesen, what would you add on to the P217 if you needed to add one or more inflammatory biomarkers?
Yeah, that's a very good question. But in plasma, the inflammatory biomarkers may be responsive to other organ inflammation. So that's very difficult to identify one. So for that, I think we need to refer to extracellular vesicles, brain-derived extracellular vesicles, and look at their contents in terms of within the membrane or inside. Within the CSF, I do think there are some interesting candidates like TREM2 in Alzheimer's disease, YKL40 or chitinase 3 like 1. Chitinase 1, so as a separate protein, also a member of the chitinase 3 like 1 protein family, is also one that always pops up in our proteomic studies and has a high fold change. But we also showed that TGF, I have to say it right, IgG-B2, so integrin B2. So it can also be relevant to extracellular matrix components, but that marker consistently showed an upregulation in Alzheimer's disease, and also very early on in preclinical AD, what I showed in my plots also, and it seems to be elevated in MS as well. In a meta-analysis that we recently performed. So I think that's an interesting marker to keep an eye on. Perhaps it could reflect blood-brain barrier damage, but we need to do more research on that.
Yeah, great. Thank you so much for the answers. I think everyone can agree that we're not quite there with the inflammatory, but the progress with the p-tau217 went quite well, surprisingly well. So hopefully we can also accelerate the inflammatory biomarker in that direction. So I agree, there's a handful of people in the chat saying thank you very much for some good talks today. So thank you to both Professor Henriksen, Tunissen, and Tobias Seibek, who was unfortunately not able to be here at the discussion. But thank you very much for everyone listening online. And then just to finish off, I hope to see many of you in Copenhagen next year. Again, we cannot promise sun, but at least we can promise good science and a couple of social events as well. So hope to see many of you in Copenhagen next year. And again, thank you very much for the speakers and everyone attending this webinar.
Thank you.
Thank you.